Hello, everybody, and welcome to ICMDA webinars. I'm Dr. Peter Saunders, the Chief Executive of the International Christian Medical and Dental Association. But today is quite a historic occasion because it's our 250th webinar since we started back in COVID times in 2020. So it's a great pleasure for me to introduce an old friend, Nick Herodotou. Palliative medicine is the symptom management of any patient who has an irreversible, progressive, life-limiting condition, and it's not solely cancer patients. It aims to enhance quality of life, utilizing a holistic and multidisciplinary approach. A good symptom management of palliative patients is what every clinician should be able to deliver. And this webinar is going to address the practical management of how to commence strong opioids, palliative surgical interventions, palliative emergencies, and lastly, when you stop treating a patient who's clinically deteriorating. Dr. Nicholas Herodotou studied medicine at St Andrews University in Scotland, earning a BSc in the medical sciences, and then he trained at St Bartholomew's Hospital, Medical College, London, qualifying in 1994. After GP training, he worked as a locum in general practice and psychiatry before choosing palliative medicine. He completed specialist training in Warwickshire in 2007, and he became an NHS National Health Service consultant in Luton in the UK in 2009, focusing on holistic care in acute hospitals. Nick's passion is to make a difference to palliative patients so that they die with dignity and respect. He's the former president of the Motor Neurone Disease Association local branch and also a lecturer at University College London. Nick's married to a former dentist and they have 4 children, and he enjoys playing squash and also running marathons. Nick, it's such a pleasure to have you, and we really look forward to hearing what you have to say and to interacting with you in the Q&A. So over to you, brother. Thank you.
Thanks very much. Lovely to have everybody here, although I can't see you. Thank you so much for joining me. It's a shame I can't see you all around the world. I usually like doing in-person lectures because I think you can interact with your audience. But this is an important webinar, so it's always my pleasure to teach people about managing their palliative patients. So this is a really important slide. You can say a lot in a picture. Now, just in case you're trying to work out what it means, you're the clinician, that's your hand. The soil is the treatment we give patient, and the seedling is the patient. Overwater it, you make it wilt. You never give it quality. If you underwater it, also you cause more problems. So medicine is always that balance of benefit versus harm. You want to do the right treatment to enhance that patient's dignity and quality to life. And I'm going to touch 3 essential points. What is palliative care and its subdivision, managing palliative patients, and lastly, I'm going to talk about the important issues around how do you stop treating a patient when they're really clinically deteriorating. And that's probably one of the biggest issues doctors face today because of the advancement of medicine. People find it very difficult to know when to actually stop treating a patient. I might avoid some slides for the sake of time, but I'm going to go through most of them because I think they're important. Now, this is a bit of a joke. The nurses sent me this mug because the doctors in the hospital call me Dr. Death, not because I kill my patients, but because everyone sees me as the Grim Reaper. Whenever I turn up, they say, oh no, Dr. Death has turned up. But palliative medicine is not just about right at the end. And that's where people, I think, go wrong. They always call me when they literally overtreated their patient for weeks on end, causing unbearable suffering to them, losing their dignity, and they decide to call me to tell the patient that they're dying. So that's not really what a palliative medicine doctor should be doing. All doctors who practice good medicine should know how to deal with the dying patient. That's what makes medicine so worthwhile, because we give dignity to our patients from beginning to the end of their life. So how do we define palliative care? Well, it's changed a lot. As you know, palliative care was started in the UK. So if you had to define palliative, it comes from the Greek word, literally means to give comfort care, but it's any progressive, irreversible, life-limiting condition. In the past, it used to be seen as solely cancer, not now. And there's lots of conditions that are deemed palliative, i.e., chronic lung disease, chronic cardiac failure, etc., motor neurone disease, and other neurological conditions. These are all palliative, and the aim is to ensure quality and dignity to that life. It's not reversible. It's going to get worse, and it's going to take their life earlier. And some people get confused with what's called end-of-life care. Now, I think it's a misleading term, but in the UK in particular, end-of-life care is deemed the last year of life. And shortly I'll show you a little graph which explains that. And it's to enable, especially those doctors in primary care like GPs, to start to plan for people in the last few months of life. But realistically, it's more easier to diagnose someone in the last 6 months of life rather than the last year. And this was taken from a paper that was published a while back. And if you can see on the graph, end-of-life care is the last year. But the dying phase, or what people commonly call the palliative phase, is really the terminal phase of a patient's end. And that's really the last 2 weeks of life. So when we think people are rapidly deteriorated and dying, I use what's called the terminal phase. And that's sort of the last stage, so less than 2 weeks. So please don't get confused when you hear those terms. So palliative doesn't mean they're immediately dying. That's what I'm trying to highlight. And the reason we talk about holistic care is that when we have a multidisciplinary team meeting, we have different people involved in supporting patients and family. And this is a nice little picture which helps you to understand. It's physical, and with the man here, it's psychological with the brain, it's social with the hands, and it's spiritual. And people aren't just flesh and blood. Right? I believe we're made in the image of God, and that all these attributes are really important when you're dealing with people, especially regarding pain. Pain is not always physiological. It's psychological, it's social, it could be spiritual anguish. And that's why it's important to seek to address all these. Now, not everybody is going to have a strong faith, but I love this quote from a man called Ramanujan. So if those of you from India will be familiar with him. He said, an equation for me has no meaning unless it expresses a thought of God. Now, this was a Hindu, brilliant mathematician from Madras, went to Cambridge University. And if you watch the film The Man Who Knew Infinity by Dev Patel, it's all about him. Now, this man as a Hindu understood maths because he realized it was logical. And logic gives you a beginning and an end. And he understood that mathematics reveals the mind of God. So this is why I think palliative care is so important, because it seeks to address every aspect of a person's well-being. Now, as I said earlier on, the UK has the best palliative care in the world. Why? Because we established the modern hospice movement in the UK. So if you look at this taken from the BBC, we're number one. Unfortunately, Iraq is at the bottom of the list. So any of you from Iraq, let me encourage you to learn palliative care so you can transform your country with good palliative care. And this was what's called the modern hospice movement, was established in London by a lady called Dame Cicely Saunders. Now, prognostication, that's all about, from the Greek word, how do you tell how long someone's got to live? Well, when it comes to cancer, which is the black line, it's relatively simple, depending on what cancer you got. For example, if you had an advanced pancreatic cancer, you know there's going to be a time limit for that patient. When you get to organ failure, you're talking about end-stage chronic lung disease, cardiac failure, etc., or neurodegenerative, some of them, and that's the red line. And the blue one is probably people like dementias, which can linger on for years and much more harder to prognosticate when they're in the last months of life. Now, if I had to say to you what was the best cancer for a man, I can't ask you this question because I can't get feedback, but the best cancer for a bloke, believe it or not, is testicular cancer. You can have metastatic disease with lung metastases, brain metastases, surgery, radiotherapy, chemotherapy, you'll get 99% 5-year cure rate. It's very chemo responsive. Unfortunately, if you look at the bottom, lung cancer, pancreatic cancer is the worst cancer. All right, even now, it's strict. If you get metastases with pancreatic cancer in your liver and your lungs, you're looking at probably less than 6 months on average. Now, the best cancer for women is not breast cancer. In fact, it's melanoma. And the reason I usually say this to the audience, that women are very fastidious about their spots. the slightest spot they notice, they will immediately get seen. So they get picked up very early, superb prognosis, virtually a complete cure. And breast comes second. These figures haven't really changed much even today. Again, pancreas, liver, lung, not good cancers to get even in women. So one of the biggest difficulties, I think, in medicine today is communication, especially in the UK. If you look at the complaints, the majority of it because doctors do not communicate well, especially in primary care and secondary care. Even now, biggest complaints is doctors do not explain to their patient what's happening, especially regarding the truth. They tend to fudge the truth and don't tell patients that they're dying, etc. And I like this quote. This is probably one of the best quotes for communication. I'll tell you who it is in a second, unless you can work it out. If you talk to a man in a language he understands, that goes to his head. If you talk to him in his language, that goes to his heart. Nelson Mandela, believe it or not. Now, what that's basically saying is if you start speaking the Queen's English to somebody from Outer Mongolia who only speaks Mandarin or whatever they speak, they're not going to understand you. Similarly, when you're talking to a patient, you've got to communicate in a language that they can understand, not above them as if you're so important, but to be on an equal with them. And that's where you gain respect and you get the most information from your patients. So communication is vital. You either do it the hard way or the easy way. And I'm going to show you a video in a minute now, which is how not to break bad news. And it's from a man called Louis Theroux. He's a BBC reporter, and he's in a leading hospital in Los Angeles. And the oncologist is trying to tell this young man who's dying that he's dying. But I just want you to watch it, and hopefully it will work quite well.
Dr. Gould had arranged a meeting with his surgical team.
Yeah, no, I got the whole team here. So that we could talk with you and answer any questions that you had. So we'd have everybody. How are you doing? How are you feeling?
I'm okay. Just trying to position myself.
So we all met to talk about where things are at with you and with your cancer and with the surgery and with your healing and needing more pain medicine. And we've been doing everything that we can to try to help the wound to heal. But we've just hit a roadblock where it's not healing any further, and that the area around the wound is starting to break down. And so we've been talking about what our options are to try to help with that. We wanted to get both of your surgeons in the same place to talk with you about that. So
I want CJ says he does the most to talk about it.
Yeah, I mean, when we look at the progression at the time of the APR, the abdominal perineal resection you had, we took viable tissue and we brought it into the perineum area. And then when we look at the way it healed, well, unfortunately, the surrounding tissue is not integrating the flap. And so that's what we were brainstorming about. It's like, what are the likelihood if we bring another tissue that the same type of situation will again arise and then place you in a worse situation than what you are at this time?
So what does that mean? I have to, I'm just stuck with trying to make this heal or what?
yeah, we're unfortunately at a place where it's not healing and it doesn't look like it's going to heal. And so it's about what we can do to keep you comfortable and to take away the pain. But we're not going to be able to make it better, unfortunately.
Okay.
Okay. So it's about looking at comfort measures and basically hospice. The best that we can do for you is to focus on not doing anything which is going to make you feel worse and only give you treatments which will help you to feel better.
It just seems so simple yet so complicated. I don't understand it.
The tissues just aren't healing, Dante.
It's the toughest decision for a surgeon not to be able not to offer surgery, and for an oncologist not to offer any treatment options.
Okay.
So coming to this decision,
Thanks.
I can't imagine how hard it is on you, but it's pretty hard on us too.
Thank you for the news, and maybe a miracle come out of it. I don't know.
We'll still be here checking on you and taking care of you. That hasn't changed. It's just the direction of our treatment has changed so that we can make sure that we're keeping you as comfortable and as pain-free as possible.
Okay. Comparing.
John.
God is our shot. Give it to God.
Well, there we are. You can see that's how not to break bad news. I tell you now, the only person that gave true compassion and empathy was that, I think she's a nurse. Look how she's giving eye contact. Your body language is very important. Please don't ever break bad news like that. You're going to go down on the same level and ask the patient what they understand is going on. And they avoided the most important question, that he's dying. They didn't use that word. You must use that word with people are dying so they can prepare. So I'm just going to go a little bit quickly on these ones. And I'm conscious that in some countries you have a real limitation on what drugs are available to prescribe. Just out of interest, heroin is dimorphine. This was developed by a German company, Bayer, in the early 1900s, and it was used for cough suppression in children until they realized all these kids were becoming junkies, so they made it illegal. In the USA, you can't prescribe dimorphine. It's banned. We prescribed the most dimorphine in the UK, but unfortunately, there was a shortage of supply because of Afghanistan. And so we can't get hold of dimorphine in the UK now. And we were the most prolific prescribers of it. It's a great drug. We use mostly morphine now and oxycodone. There are probably some drugs that you can probably get hold of. Just to show you, there is a potency ratio. And if you get codeine, it's 1/10 as strong as morphine. Oxycodone, we use generally first line in renal impairment. And that's twice as strong as morphine orally. And dimorphine, well, it's hard to get hold of. Methadone we also use, but I use very sparely in patients with very, very severe pain syndromes, and it's done in a specialist unit. I wouldn't recommend you trying to prescribe methadone. And again, fentanyl, it depends if you can get that as a patch in your country. The take-home message I want you to know for more opioids is that please use a laxative. Whatever laxative you can get hold of in your country, you must start non-laxative. You don't want your patients to get opioid-induced constipation. People don't generally get nausea with oral medication. It's usually if you give it intravenously. And generally speaking, in palliative care, we tend to give it subcutaneously. And that makes it a lot easier in the community where a nurse can administer a little injection of morphine or whatever you have under the skin. And there's no absolute contraindications to opioid prescribing. There's also no absolute upper limit. It's all about titration and how much a patient can tolerate, because patients develop, tolerance, and after a while they need much more. So it's all based on what a patient has already taken. Now, as a very quick way of learning about how to use opioids, please don't be scared. And the best way to do it is do a titration. So let's say someone is very opioid naive. You've never given them codeine or tramadol, and you don't know really how much morphine they need. You don't want to just start on a slow release medication because you may not know if it's going to work. Secondly, if it's too strong, you will make them very, very sleepy for 12 hours. So as a rule of thumb, you can give regularly a short-acting opioid such as Ormorph liquid or Sevidol tablets if you have it, and tell them to take it every 4 hours with a laxative. And then what you do is you ask them the next day whether they responded. And if they responded well to it, you've got an indication of how much they need. You can then convert that to a slow release regime. So for example, if they were taking 5 milligrams every 4 hourly in 24 hours, and you ask them the next day, how's their pain? They say, oh, doctor, the pain is much better. 1 out of 10 is the least, 10 out of 10 is the worst pain, and it's gone down to 1. So you can then convert them to MST or morphine sulfate tablets, slow release, 30 milligrams BD. And then what you do is that you always give them as needed medication. And you do that by dividing the total dose by 6, because the half-life of a short-acting opioid is 4 hours. And there are 6 lots of 4 hours in 24 hours. So if they're on 60 milligrams, you divide it in 24 hours. You divide that by 6, and that gives you 10 milligrams, say, of short-acting Ormorph as required. And as I said, after a while, if they're starting to require the PRN again more frequently, add up the total dose and readjust it to a BD regime. Opioids are very simple to use if you know what you're doing with them. And as I said, there's no upper limit. It's all based on how much the patient requires on a regular dose. And this is just an example, but I'm going to just speed ahead here a little bit. Just in case some of these drugs may not be available in your country, but non-steroidals are very useful for cancer pain in bone, providing their renal function is okay. Now, having had a recent GI bleed or severe AKI, you can try that. I don't know if capsaicin cream is available. It comes from a chili plant, but it's very good for localized pain like rheumatic pain or osteoarthritic pain on the knee joint. We have lignocaine patches here in the UK. Again, if it's very tender bone pain, like a rib fracture due to a cancer, you put that patch on for 12 hours overnight. It works great. And I am a fan of benzodiazepines. I tend to use clonazepam, which is a long-acting opioid like diazepam, has a 12 hours half-life. I use that for breathlessness, for high anxiety states, and for pain. And it's extremely useful alongside these, especially in the palliative setting I'm talking about here. I'm not worried about addiction with patients who have very advanced cancers. And steroids is really a panacea for all illnesses. Yeah, if something doesn't work, try steroids. And we tend to use dexamethasone if you have it in your country. 1 milligram of dexamethasone is about 7.5 milligrams of prednisone, and it's extremely useful. I use it ubiquitously for my cancer patients predominantly. And just as a take-home message for vomiting, without going into too much details, if you're going to use an antiemetic, do not use metoclopramide with cyclizine because they work on different receptors and they also antagonize each other. If you've got someone, for example, with malignant bowel obstruction and they have no colic, you can actually use a prokinetic like metoclopramide. It's not contraindicated. Contrary to what people say in mechanical obstruction, it is non-cancer if there's lots of bowel sounds. But in cancer patients, it's normally a neurogenic bowel. So you can safely use a prokinetic like metoclopramide, but don't use it with cyclizine. In fact, we use haloperidol, which is off license, which is an old antipsychotic. We use a very low dose. That's a really useful drug. And there's another old antipsychotic called Nozinan or levomethomazine. You may have similar drugs in your country. Try using low dose. They actually have an antiemetic side effect, which is really useful to use. And again, this is using off license, but as long as you can justify why you're using it. So again, I'm not sure if these are available in your country, but we commonly use in the UK and in Europe what's called a syringe driver. And I call it the patient-controlled analgesic pump minus the P. In other words, the patient can't press anything. So I use this a lot for acute symptom control. People seem to associate the syringe driver with the dying patient. That's not true. If you have this in your country, and I appreciate in a lot of countries I don't have it because they're expensive, but it delivers the drug every hour for 24 hours and it's subcutaneously. The patient can't press anything on it. It goes by itself and the district nurses generally change it themselves. If you don't have such a device, if you can try and innovate to put the drug somehow in a subcutaneous route, it can really help the patient in severe pain or even at the dying phase. Now, this is a little bit of pictures for you. So where we actually do interventions even for advanced cancer patients. The one we've got here is a lady in her 90s who had metastatic renal cell carcinoma, who, believe it or not, her son rolled her on the bed and she snapped her femur. And she was in agony and the surgeons didn't want to do anything. And I had to push them to do it because we felt we would not be able to control her pain adequately. So the surgeons agreed to actually, as you can see here, they actually rodded her femur. And it made a huge difference. Otherwise, she would have been confined to a trauma splint for the rest of her days. This other case is very sad. He was a 39-year-old man with what's called a chondrosarcoma. If you look at the X-ray on the left, that's a massive tumor. That's his leg. He's completely snapped it. That's a pathological fracture. And they went to operate on him, probably reluctantly. I went to see him and I missed the boat. He actually died post-operatively, probably from a tumor embolism. Had I seen him, I probably would have advised them not to have operated because he was so ill and there was a high risk of death. And this is a very sad case, unfortunately. Just for your interest, this was a young man who had what's called a malignant melanoma. This was many years back when I was a registrar. They tend to metastasize to the lymph nodes. He was in extreme agony. This is where a syringe driver to control pain is really useful. Very sadly, he died from that because this was before the invention of immunotherapy and he didn't survive, unfortunately. The next case was a paper I got published. Well, as a registrar, this is a man who's got toxic epidermal necrolysis. It's the worst form of drug-induced skin reaction, and it's the only time a dermatologist would come out in an emergency. He had a brain tumor called a glioblastoma, and he was given phenytonin for his fits, and his whole body desquamated. So with toxic epidermal 10, you get a 90% burn. You won't survive it. I mean, we had to sedate him in the end, and we didn't transfer him to a burns unit, and he died with dignity, thankfully, in the hospice. Okay, I'm going to touch on a couple of emergencies here, and I'm going to give you a take-home message. This is what's called malignant spinal cord compression. I'm going to see if I can show you as with a little marker, with a marker here. If you see that, this is an MRI. This is your spinal cord, and there's a big tumor there, and that's pressing on the cord there. Okay, so this is called compression. In malignant, any cancer patient that you have who starts presenting with back pain, it's called compression until proven otherwise. And my advice to you is to get them scanned straight away. Do not delay it. It doesn't matter if they've got normal neurology. Don't think about anal tone, because that's the last thing to go, your autonomic function. Any cancer patient that you know who you've seen and they start saying, I've developed back pain and it's been over the last week or few weeks, I would do an urgent MRI straight away. I'd put them on steroids, at least 12 milligrams of dexamethasone or some steroid, whatever you have, with some stomach protection. Get an MRI scan, because if you pick it up early, you can prevent them from going completely paralyzed. And that's really the take-home message I want to give you for that one. So this is what's called an event in PEG. So I started this service very early on when I was a consultant in the hospital. This is a patient who's got irreversible malignant bowel obstruction. So the surgeons can't bypass it. And when a patient is profusely vomiting, I will put them on a syringe drive and try and control their symptoms. And failing that, the last thing we do is actually what's called a venting gastrostomy. So if you can see, it's a big tube. It's a bit like a feeding tube, but it's actually a 25 French. It's really wide. And I get my upper GI surgeon colleague to do it for me. And we've done a few of them now, but it's really only for the last few days of life. And they put it in like via a gastroscope, and there's a spigot. So if the patient wants to eat, they close the spigot. And if they feel they're going to be sick, they just open it. This really enhances quality of life in the last few days, because once you put it in, they literally only have a few days of life left. So it's a useful procedure, but it's a palliative procedure merely to give a patient their dignity in their last days, so they're not vomiting profusely and not able to, enjoy a bit of food. You don't want to have a Raj tube in a patient for a few days at home. It's horrible, and patients don't like it. Very quickly, hypercalcemia of malignancy. All I'm going to say with this is that it's one of the reversible causes of dying in cancer patients. Please check the corrected calcium in your patients. All you need to remember from this is that your skin, your bones, and your kidneys with sunlight control your calcium regulation. And the main one is that in cancer patients, you get what's called parathyroid hormone-related peptide, or PTHrP, which is released exogenously and by the cancer. So the body thinks you haven't got enough calcium in your body. So the bones chuck out more calcium. So you get increased osteoclastic, you get increased skin absorption, and plus the kidneys don't pee out as much calcium. Hence you get this huge surge of calcium, and they will die from a cardiac arrest. And the treatment for it is IV fluids and a bisphosphonate. Whatever you have, generally we use zoledronic acid or permisionate intravenously. That buys them a bit of time, but it's often a poor prognosis because it will come back. And they reckon on average, probably less than 3 months survivability. Another emergency, this is all palliative treatments, you see. This is called malignant ascites. The difference between malignant ascites and non-malignant ascites, such as cirrhosis, is that it's an exudate. That means is that you can drain their ascites with a temporary drain, and you do not need to give albumin replacement. Only in patients with cirrhotic livers or they have a mixed picture should you give albumin replacement. But in cancer patients, you do not need to give them albumin replacement when you drain it, because it's exogenous. They don't decompensate, and you can drain liters from their tummy. And you don't clamp it, contrary to what people try and teach you, because you have a risk of getting an infection if you keep the drain in. So we put it in temporarily and remove it. And we did have a good pathway where we could put in a permanent drain if they get recurrent malignant ascites. And all I'm going to touch on here is the neurodegenerative conditions. And I had an interest in it because I used to see all the newly diagnosed patients. I'd be very careful about trying to give artificial nutrition in patients who have an advanced progressive neurodegenerative conditions such as motor neuron disease. The evidence is not overwhelmingly conclusive. Secondly, they do aspirate with the feeding tube. Thirdly, you prolong their suffering, because what you're doing is they're going to die eventually from an aspiration, because if they lose their bulbar reflex, they can't swallow. And I had a recent patient who had severe mental health illness. She got diagnosed in her old age, and I advised the team not to put her feeding tube in. They did, and her suffering was prolonged. I told them to stop it, and I sent her home to die, to a nursing home. And the family were extremely grateful that I intervened and said, do not feed her artificially. It's cruel. Unless they have to be alive for something, such as a marriage or some special event, that's a different argument. But do not put them in unless you explain to the patient that the natural end of their illness is generally an aspiration or a respiratory arrest from motor neuron disease I'm talking about. And this is this interesting slide from a leading palliative medicine professor in London called Rob George. And this is some guidance on about patients who have what's called persistent vegetative states. So they're completely unresponsive. And I've highlighted in red, probably the most important ethical question you should ask when you're treating patients is in the giving, not the withdrawing of treatment, that needs to be justified. So too often in patients who are very ill, we try and justify why we're giving a treatment. We should it's the other way around. We should justify why we're treating them rather than not treating them. And that's always the careful balance of benefit versus harm. Let's move on. So I'm getting towards the end now. So some of you may be familiar with this. It's the 4 principles of ethics. Of autonomy, which is the right for the patient to have a say in what they want to do. Beneficence is do good. Non-maleficence is do no harm. And justice is you get the same treatment for. So if you're the King of England, you don't get better treatment than the ordinary citizen who just works in the street. So you want to give the fairest treatment to all. And it's really important, whatever country you're from, is to ask yourself the question, am I improving this patient's quality of life by doing this treatment, or am I making them worse? And too often we overtreat. Now, if you look at why people are living longer, it's because of this. Cardiac treatment has gone phenomenal. It's reduced cardiovascular disease, public health, nutrition, etc. All these have had a huge impact on how long we live for. And this is a really useful tool, which you may not know of. And it's about how do you identify a patient who is clinically deteriorating. And I'm just going to highlight 2 very quickly, called the SPICT and the ECOG, and I'll show you what that is. And this is a really helpful tool if you're in a hospital in a community and you're seeing patients and they're deteriorating. These are tools to help you identify, is this patient actually dying or getting much worse that we need to reconsider what treatment we're given. Now, this is downloadable from the website called Supportive and Palliative Care Tool. All that is on the left, is that it's helping you to highlight the different types of conditions that you could say, is this patient approaching a natural end? Are they in the last few months of life? So dementias, vascular disease, respiratory, renal. It's there purely as a help. And the Eastern Cooperative Oncology Group, this was initially formed in chemotherapy trials to determine how fit someone is for chemo. Just so you know, any person with a performance score of 3+ will not get chemo in the UK, with the exception of gynecology and small cell lung cancers. So how fit they are is an indication of whether they're suitable for chemo. But it's useful as a way of assessing someone clinically if they come into hospital or your community clinic. So if you saw them last month and they had a performance score of 2, so they're active for more than half a day, but now you've seen them and they've gone to 3+, and there's nothing you can reverse clinically that you can see, you can then say, I think this patient may be dying. So it's a useful tool to consider. Now, if you look at America, the biggest reason that doctors will overtreat is malpractice. And I think it's happening probably a lot more in our country than the UK. It may be less so in your country, depending where you're from. But doctors really struggle because they're fearful of litigation. And how do we know someone has died? Well, I'm sure a lot of you in some of your countries are very aware of this, but in the UK and probably in Western cultures, we tend to hide away from dying. And the three principles are really they're clinically deteriorating, i.e., their performance score or whatever scale you want to use, they're getting worse and worse despite the treatment. They're not eating and drinking much, and there's nothing you can find that is reversible. And what I mean by reversibility are things like sepsis, dehydration, high calcium, and believe it or not, urinary retention. The number of times I've picked up patients who are in severe renal retention because they haven't peed for 24 hours and no one's examined their bladder. And they will be in extremis. You think they're dying, but put a catheter in, they're happy as Larry. So there is a time to stop, believe it or not. And the number of times I'm involved often in advising on the wards. I don't have my own patients, so I'm an expert. I go around and give opinions to doctors who ask me. Now, this is a lady, very sadly, who was 36 years of age. And what happened with her is that during her pregnancy, at 9 months, she had preeclampsia. They had to deliver her, and they found she had a massive liver abscess because she was spiking. She then had a PE, and she was on warfarin, and they discovered she had a huge cholangiocarcinoma in her liver. You can see the scan from November to August, from 23 to 24, and her platelets were 4, and the professor in London didn't tell her a thing, and I had to tell her that she was dying, and she said to me, the professor always avoided discussing it with me, and I had to tell her, I need to send you home to die because you're not going to survive. And very sadly, we sent her home. She died within 4 days. And had I not informed her, she would have died in the hospital and not had a chance to say goodbye to her little children, a 5-year-old and a 9-month-old. And this is another patient. Just all you need to know, this man had huge problems. He wasn't cancerous, but he had what was called an enterocutaneous fistula. And when he came in, he was in several times. His INR was 20. He was so ill, and he kept saying he wanted to die. And his fistula output was 2,200 mils daily. And this was his tummy. I've never seen a man with so much fluid coming out of his tummy. And he kept saying he wanted to die, and nobody was listening because they were treating him to death. And I said to him, you have a legal right to stop all treatment, providing you're not deemed to be mentally ill, and that you should be allowed to die with dignity. And I did emphasize, this is not assisted dying. This is not euthanasia. You're dying because of the huge multiple comorbidities that you have. And the man was so ill. And he said to me, you're the first doctor that's listened to me. I got the psychiatrist to agree that he understood the repercussions to stopping artificial feeding. We stopped it. We sent him to the hospice, and he died within 5 days of dignity. And there's a case where I deliberately stopped the treatment because this man was dying, but nobody would listen to this man's autonomy to have the right to say, no, I've had enough. That's why in the UK, we do what's called a do not resuscitate. It's a legal document that the doctor signs, not the patient. Patients can't refuse it, nor can the family. They're entitled to a second opinion. So often their doctors will ask me to come and give an opinion. But it's something we do sign because you do not want to resuscitate a patient who has got an advanced illness. You're going to cause more suffering than good. Please have those discussions with your patients. It's cruel to try to resuscitate somebody who's reaching the natural end of their life. Because people at the end of the day want to die with dignity, ideally in their own place, in their own home, with spiritual input with their family, and to have to say their goodbyes. People want to have closure. Because medicine is not just technical, it's an art. And I think we've lost the art of medicine. We need to re-engage with students in medical school, teach them the art of medicine. We need mentors. We need someone who's a good clinician to teach these students how to be good doctors. Because at the end of the day, ladies and gentlemen, patients aren't always interested in how much you know. That's important. They're also interested in how much you care. And I'm going to close. I should say this is a link to all the talks that I've done on YouTube, courtesy of a medical student who videoed me about what is palliative medicine, how to discuss do not resuscitate, and how to tell a patient they're dying. They're all on there. It's public domain. And also there's a recent paper that has been published on managing your palliative patient. It's open. You can download that from the website. You don't have to register or subscribe to it, from the British Journal of Hospital Medicine. And I'm going to close with a video
Now then, after decades of suffering with insomnia, last night, Brian Wood from Luton had his first good night's sleep in 50 years. Amazing.
Yes, but he had to go to some pretty extraordinary lengths to achieve it, as did his local hospital. Ellie Price takes up the story.
Brian Wood has been looking after the churchyard at Sundon for 10 years. There's always lots to do at this time of year, but time isn't something Brian has. He's suffering from terminal cancer and has been given just weeks to live. But he's determined to make the most of that time. Brian's a chronic insomniac and says a good night's sleep would really help. So doctors at the Luton and Dunstable Hospital have agreed to give him that one night's rest by anaesthetising him.
I'm just excited at the thought of it and the thought of the energy and the well-being that it might give me afterwards. My dying wish
Give them a few hours.
is that this would enable me to make Christmas.
Brian says he hasn't slept properly for 50 years. Last night he was anaesthetised in a similar way to patients undergoing an operation. His doctor admits he gave Brian's request a lot of thought before agreeing to it.
Providing ethically, the benefit outweighs the risk, and the patient understands that. It's not unreasonable to give it a go. And in this particular case, this is my first time ever I've got a patient anaesthetised purely to enable them to sleep.
You okay?
Yeah, right now.
Yes? Put your eyes open.
After 6 hours, Brian was woken up, a bit groggy, but happy.
I know I'm going to feel better for that later on today. Glad.
And he did. Just hours later, he was back at his beloved church in Sundon. The place holds special significance. Sadly, his son Jason died 2 years ago. His grave is there.
This is where I'm going, and I've already prepared my little place because this will never be disturbed again. I shall be cremated.
Brian says he's not being morbid, just realistic, and his sleep has put him in a very good mood.
I can't stop laughing for one thing. I've got this chubby face because of the steroids, whereas normally I'd be looking a bit ill and gaunt, and which makes me look well, and that makes me feel good. And I've had this sleep, so I can't stop laughing. Why would I stop?
And he's determined not to stop, certainly while there are lawns to be mowed. Ellie Price, Anglia News, Luton.
And I think that's it. So that, just out of interest, that patient there, I saw him in clinic many years ago. He couldn't sleep for 50 years. And I tried every other avenue. He just wanted to have a general anaesthetic. It made a huge difference to his dignity and his quality. And he lasted, in fact, 4 months after that. And he died well. So it made a huge difference to him. And it's not the sort of thing one would normally do. But that's the good thing about palliative medicine. You can do things that are not the norm. And it can make a huge difference to a patient. Thank you for listening. That's the end of my presentation.
Well, thanks so much, Nick. That was quite something. A really inspiring story to finish with, and beautifully illustrated how you need to really tailor the treatment to the person and give them the best possible last days that you can. We've got a bit of time for Q&A, and the most popular question here that's come up is this one. Nick, thanks for your presentation. Do you have any advice about discussing spiritual care in the final phase of life? Christian doctors often feel it's their duty to do so, but they may be at risk, especially in Western Europe, of being accused of exploiting a situation of dependence or vulnerability, and hence referral to the medical regulator. And you talked about US doctors being worried about, accused of malpractice and so on, and therefore erring on the side of over-treatment with physical treatments. But do people err on the side of under-treatment with spiritual interventions? So your wisdom on that.
It's a very common question I get asked. And I think the key thing is that, first of all, good GM, General Medical Council, good medical practice is actually spiritual care forms an important part of a patient's well-being. Now, the advantage of patients who are very, very ill is that, some people want spiritual input. You have to be careful. You can't, patients are vulnerable in that sense. You don't want to use them as a way to just bash them. And so I never do that. I always ask people if they have any spiritual needs to help them. Thankfully, in our hospital, we have a very good chaplaincy who actually believe in the gospel. So there's not many hospital chaplains who actually are practicing Christians. And so I usually say to patients, if you have any spiritual needs, we have a chaplaincy who will see anybody and will support you. Saying that, I've also, with the right patient, I've said to them, if you don't want anybody religious, I also happen to be a practicing Christian, and I'll happily pray for you privately when I go home. Now, I always say that first so the patient doesn't feel pressurized to have to say yes. Or I said, I can even pray in front of you if that's what you want, and share with you the hope that I have as a Christian. And it's interesting, the number of times I've had patients say, please pray for me. Sometimes I say, pray for me at home or pray for my family. So it's, first of all, it's not wrong. It's context. It's the context. If someone is very, very ill and you ask them if they have any spiritual needs, it's completely appropriate to ask that. Secondly, it's appropriate if you're able to do so, and if they're very happy for you to pray for them if they request that. But again, I have to emphasize, you mustn't use your position of authority to try and coerce a patient. That would be unethical. So there's a very fine balance. So I've never had any issues with that. As I said, it's always the context. I'd encourage you to seek, if people want spiritual input. Thankfully, we have very good chaplains. If you don't have that in your hospital, you can always say, if you feel you'd like praying time, we can get someone, or I can even pray for you if you want that later on. That helps.
No, that's great. And often it's you they've got the relationship with, so they may actually prefer to pray with you. Now, you talked about the good and bad ways of breaking good news and showed that video with people using jargon, standing above the patient, not really being honest with them, not showing any empathy or whatever. Can you just give us a few pointers, what you've learned over a career in palliative medicine about the best way of breaking bad news to a patient?
Okay. As I said, if you watch the video later on that YouTube, it really helps. But I think the thing that's really important is to put the question to the patient, put it in their court. And I often, when I go to see a patient, I can see they're clearly dying. Instead of saying you're dying, I say to them, tell me what you think is going on. What have they told you, first of all? What do you think is happening to your body? Most of the time, patients will say, oh, I'm knackered, doc, or I'm dying, doc. And I say, yes, you're right, you are dying. So that's a very good way to introduce death and dying to a patient, is to actually ask them what they think is going on. And then you can then take them further and say, okay, where would you like to be? What do you want to happen to you? Do you want to stay here? Do you want to go to a hospice or home? And some people are really clueless because the doctors haven't told them the truth, or they've been evasive with the truth. And I will then say, how do you want to hear this information? Do you like me to tell you straight in black and white, or do you want to hear little bit at a time according to what you can tolerate? And a lot of the time people say, I just want to hear it straight, doc, just tell me the truth. And because people get very angry because they get mixed messages from one side of the team, they're all proactive, actively managing and investigating. I come along and say, stop everything and get this person to their preferred place that they want to be in. And that then causes conflict with family because they're getting mixed messages. So it's important to be truthful, to listen to the patient as well. Now, I think I need to learn to listen a bit more sometimes, because sometimes I talk more than I listen.
Can we just pick up that issue of the family? Because everyone's in some kind of family context. And the question here is, how do you tactfully navigate the two narratives that arise between the treating physicians who've omitted information about a poor prognosis due to requests by family members on the one hand, and then your ethical duty to the patient regarding their disease trajectory? And I guess this is hinting at the situation where relatives are told first rather than the patient, or where the patient. Do you have the relatives around? Do you speak to them separately?
Okay.
Some words on that.
Depending on what country, in the UK, but no patient or even relative has the right to demand what is deemed to be a treatment that's not in the patient's best interest. So in other countries where people pay, what they demand, they get. In the UK, under UK law, no family member or even a patient can demand a futile medical treatment, i.e., I want to be admitted to intensive care unit when I get a severe pneumonia, or I want dialysis when my kidneys aren't working as well. So it really resides with the clinician in charge. And I work in a hospital where there are a lot of overseas trained doctors who don't have that sort of ethical training. They're not UK trained, so in their country they just do what the family demand, and so I'm faced with that obstacle frequently. So there's two ways to do it. First of all, I try to then connect with the family and explain. If the patient can't understand, I will explain to the patients, these are my reasons why we need to stop. We have a high Muslim population in where I work, and a lot of them think that if you don't do any treatment, it's anti-Islamic. And I try to explain that there is a natural end to our life. And I tend to use God a lot with Muslim people because they like that. Because I say, look, our life is in God's hands. We don't speed things up and we don't slow things down. But we want your loved one to die with dignity. Very rarely we've had where there's been a lot of conflict, where the family aren't listening, the consultant in charge doesn't listen. There is only so much I can do because I'm an advisory service. But it's really important, though, to help get family to realize that their loved one is deteriorating and that otherwise they can't have closure. And this is probably the biggest distress for family members when they don't have closure with a loved one. So it's really imperative that people are transparent and speak in a way that people understand. Don't use ambiguous terms like they got a tumor or they're not doing very well. I always use the word dying because it's caustic, but it's straight. And sometimes people find that a little bit distressing, but I think later on they actually appreciate it because they could say and do things that they wanted to do to their loved one before they died.
Good. And just finally, Nick, you talked about the complexity of pain. I think Cecily Saunders used to talk about total pain. You talked about pain often having a spiritual component or the anguish people have at the end of life. How do you address spiritual pain in a dying patient?
Yeah. So obviously it's probably easy if your one's in a hospice. I just work in a hospital in an acute setting. So it really depends on what issue is being addressed. I mean, rarely there's been someone who's guilt-ridden because he's been having an illicit relationship for years and his wife never knew about it. There's an issue where perhaps if they're wanting, the chaplain will come and support them and perhaps even pray for them. But you've got to consider, it's trying to work out what is the problem behind that pain. So if you've excluded something physiological, when patients complain of pain all over, that something else is going on because you can't control pain that's all over. This is multifaceted. With the spiritual pain, it would be helpful to try and work out what is distressing this particular person. I had one man who was only in his 50s who was in extremis, and I think there was a huge spiritual component to it because he couldn't forgive his mum or his sister. And he was really bitter and angry and really traumatized. So for him, actually, I ended up praying for him with his permission. I got the chaplain down to minister to him and to try and comfort him, to encourage him to forgive his family because that to him was very difficult. He couldn't forgive them.
Good. Well, again, you've emphasized the importance of making a proper diagnosis, even with spiritual things. It might be a variety of different issues that have upset them and be contributing to their anguish. So it's not one size fits all. Nick, very sadly, we've run out of time. We have lots more questions. So we'll have to draw it to a halt here. I just want to thank you, Nick, again for your for your wisdom, your experience, both professional and spiritual, in addressing this issue, which is often so badly dealt with in different places around the world. Thanks to all of you for joining us today on our 250th ICMDA webinar. And we look forward to catching up with you once more soon on ICMDA webinars. May the Lord bless you. Thank you for coming.
Thank you, everyone. Bye-bye.